This week we're looking at an often overlooked and mistreated shoulder issue, the shoulder derangement. But first, our disclaimer. Mike Matthews, physical therapist here with the PT 411. Thanks so much for joining me. If you already haven't done so, make sure you follow, like, subscribe, Facebook, YouTube, Instagram, TikTok, and Twitter. Also make sure to check out thept411.com. So the shoulder derangement. Now, some people and schools of thought may call it other things like an impingement or an obstruction. And I would say through referrals, I rarely see this as the working diagnosis. Most often I see frozen shoulder, rotator cuff injury, bursitis, arthritis, bone spurs, and so on. The problem with the derangement, it can mask itself as many of these issues, and it is really just an alteration of the position of the joint as a result of some sort of obstructing factor. Now, since the joint is obstructed, it will not move right. Since it's not moving right, muscles will work at a much lower efficiency, if at all. Sometimes the body will recognize an issue and purposely inhibit or shut down muscles. Now you have limited mobility, limited strength, and pain. All of these are signs of frozen shoulder, rotator cuff injuries, and so on. Now we may also see rotator cuff issues on an MRI that are asymptomatic, that are not causing pain or limitations. I'll be doing a video on that one soon, so stay tuned. But just because you have imaging that shows something, it may be worth your time to see if the pains respond to the derangement treatment, because it is a quick treatment. Well, relatively. You may be pleasantly surprised. It can be easy for the initial diagnosis to be wrong. I've been wrong before too, but the thing is, when I start to get an understanding and start drawing conclusions on an injury, I approach all my treatments with a little doubt. That way I'm always ready to call an audible and redirect treatment as necessary. Now, there are a few things that we can do to help diagnose a derangement correctly. If we had limited range of motion, we look at a few planes of movement. We lift the arm up in flexion, sideways in abduction, and then we look out to the side in external rotation. And then we look behind the back into internal rotation. Then we need to repeat these movements using a cane to take the work off the muscles, starting off in flexion, and then in abduction, and then looking at it again in external rotation, and finally, you guessed it, internal rotation here. Now we need to compare these. If they are limited the same, we start with stiffness or frozen shoulder treatments. If you haven't already seen those videos, make sure to go through that one first. Those can be found on YouTube and the pt411.com. But if when going through that, we see that the improvement in motion is going quicker, in 3 to 4 weeks, we misdiagnosed and it is a derangement. Sometimes we can keep going through those exercises, as general movement can be enough to reduce derangement sometimes. Sometimes it needs something more, and we'll get to that pretty soon in this video. But now, if the active movement is much less than the assistive movement, it's more likely a derangement. I will say this can also be a sign of a muscle and tendon related issue, which does include the rotator cuff. But since our derangement can mask itself as this, it's usually a good practice to explore the derangement first. If no progress is made with this, then we can explore the rotator cuff. We'll also be looking at treating that group of muscles in an upcoming video. Now, there are several movements that can occur at the shoulder, near unlimited since it's a ball and socket joint. So trying to mobilize it and reduce a derangement can happen with just those general movements I'm talking about. It can also happen with a directional preference. Now, this just means one specific movement may be the key to mobilizing that impingement. The evaluation of this can get complicated between the interview process, picking up on pain behavior patterns, and during the physical exam. For this video, we're just going to start with the most well-responded movement that I see and work our way backwards. What we're looking for is movement that overall makes us feel better and increase motion. We need to keep in mind how well we are able to move the shoulder with those earlier movements that we just looked at, as well as pay attention to how it feels during the movement. Now, it's okay to feel some pain with the movement, but we want to see that pain reduce and motion increase as we work through the set. We also compare the previous motions to see if they improve immediately after each of these these movements. We go through 2 sets of 10, see if it feels better as we go through it. If it does feel better afterwards, and if it has changed the movements from before, and once we find that this movement has done this, no need to try any other motions, just stick with that one. Do it every 2 hours, several times a day. It can take a couple of days to fully address, sometimes it can take a couple of weeks, but here we go. We're going to start with extension. We're going to take our broomstick that we've used in other videos, push the arm straight back. Make sure not to press it out towards the side as we go back. Keep the body square as we push the arm back. If we see some improvements with this, but it plateaus, come up to a counter. Hands on the counter and dip down with the legs to do the same motion. Start off light, slowly progress into that. If that doesn't work, the second most responded to exercise is horizontal adduction. We pull the arm across the body, not down across the chest. We need to clear the chest and the ribs, have it up closer to the neck, work further and further into it. Now, if we get improvement with that one, but it plateaus with this, we use the wall to go into it further. Now, if those two didn't work, the third one is internal rotation. Put the arm behind the back. You can use a towel, strap, or stick to pull it up the back. Now, if we see improvement that plateaus with that, progress by going back to the counter, arm behind the back, dip down, work light and slow, and slowly go further into it. Now, if none of those work, the fourth most commonly responded to is just flexion. We start by using that stick to push it upwards from the front. If we see improvement with this one that plateaus, we use a wall for slides. Slide it up as far as we can go, then leaning the body into it. Now, there are 2 scenarios that may prevent us from full recovery from a derangement. Sometimes the derangement may not be fully reducible. We get some resolution, but not full. Now, the other scenario is an irreducible derangement, a derangement that cannot be mobilized. This might include some sort of bone spur or tear to a passive structure like the labrum, or even a rupture to the bursa. If and when a motion that sees improvements, like a quick improvement rather, either that movement or any other movement, we need to stick with it. Tight and restricted tissues, injured muscles and tendons, they all take time to heal. If we see a quick resolution of our complaints, we can roll those things out very quickly. Not every diagnosis or test is accurate on its own. Things can be a simple fix. Let's not overlook those easy treatments. Now, next week we're looking at the false positives and non-symptomatic findings that show up on MRIs and the shoulder, so make sure to stay tuned. Again, I'm Dr. Mike Matthews, physical therapist here with the PT411. Thanks for joining me.